So good morning everyone. Last week I think the VBAC has been covered, and one of the complications of VBAC could be uterine rupture. So today we will see what is uterine rupture, what are the various types, what are the causes of uterine rupture. So it need not always be on a scarred uterus, even an unscarred uterus can also get ruptured under certain circumstances. So it is a very uncommon thing to have a uterine rupture, but then it is a life-threatening obstetric complication. And once it is a uterine rupture, it can result in catastrophic complications, not only for the mother but as well as to the fetus. So the complications to the mother usually includes the mother might go into hemorrhagic shock, and even sometimes it can result in a maternal death. And for the baby, usually it can result in a stillbirth, or sometimes even if the baby survives also complications like hypoxic ischemic encephalopathy, cerebral palsy can be seen. So once it is uterine rupture, it usually leads to serious complications for both the mother as well as the baby, and it occurs most commonly in women with a scarred uterus. So if you see the definition of uterine rupture, see it can be a complete uterine rupture or it could be only a dehiscence. So if it is a complete uterine rupture, usually it results in the separation of the entire thickness of the uterine wall, with the result that the fetal parts will be extruded into the peritoneal cavity, and even the intraamniotic contents will be extruded into the peritoneal cavity because the entire thickness of the uterine wall has given way, with the result that the fetus, sometimes even the placenta, usually lies within the peritoneal cavity. Whereas uterine dehiscence is, it is just the disruption of the muscle, but then the serosa is intact. So usually sometimes uterine dehiscence can be asymptomatic because it is only the disruption of the uterine muscle, unlike in complete uterine rupture where the entire thickness of the uterine wall has given way. So most of the times this uterine dehiscence is asymptomatic. And if you see the incidence of uterine rupture, so again it all depends upon whether it is a scarred uterus or an unscarred uterus. So rupture of an unscarred uterus is such a rare event that the incidence is very rare. So it is 1 in 12,960 deliveries to 1 in 17,000. So it is a very rare event to happen in a unscarred uterus. And after one previous cesarean section, if any patient is given a VBAC, so the incidence is 0.2 to 1.5%. Whereas if it is after two or more previous cesarean sections, the incidence is high, up to 3.9%. So this is the incidence of uterine rupture. So coming to the causes of uterine rupture, so these causes can be during pregnancy, and sometimes the causes can be during labor as well. So if you see the various causes during pregnancy, so the first and foremost will be your previous classical cesarean section. So if a woman undergoes a previous classical cesarean section, so the chances of uterine rupture will be high. So that's the reason why most of us usually we go for a lower segment cesarean section, because doing a lower segment cesarean section, it ensures that the healing is proper, and the chances of uterine rupture will be less if it is a lower segment cesarean section, unlike classical cesarean section. But for some reasons or for some indications, we had to do a classical cesarean section. And then if a woman undergoes a previous hysterotomy, again of course this is very rare because now with the advent of prostaglandins, we usually go for even second trimester terminations of pregnancy by using prostaglandins. So usually they are very effective in causing terminations of pregnancy even in second trimester. So very rarely we really resort to performing a hysterotomy. So if a woman undergoes previous hysterotomy, again the chances of uterine rupture can be there if she conceives later. And then again, if it was a scar like a previous myomectomy, usually we do it for a fibroid. So previous myomectomy, again if there was a breach into the endometrial cavity, again the chances of uterine rupture can occur. And then the placenta accreta, so because the placenta tries to invade into the muscle, the chances of rupture can be there. And then if a woman has a motor vehicle accident, particularly to the there was a trauma to the abdomen, so again it can cause uterine rupture. Of course these things are usually rare things to happen. And then if a woman has Mullerian anomalies of uterus, so again the chances of rupture can be there. And if a woman undergoes a hysteroscopic metroplasty procedures for again these anomalies, so then again there is a chance of having a uterine rupture. And if a woman undergoes a difficult curettage for miscarriage in her previous pregnancies, difficult thing, so again the chances of rupture can be there. And then there are few case reports also where the uterine rupture has been reported, and that too in a primary gravida woman, which is usually a rare thing to happen, but there are few case reports as well. So particularly if a woman has connective tissue disorders like Ehlers-Danlos syndrome, or else if a woman has been for some reason or for some autoimmune condition, if she is on chronic steroid use, or else if a mother has substance abuse like use of cocaine. So these are the things that can result in a uterine rupture even in primary gravida woman. And then what are the causes of uterine rupture during labor? So again, previous cesarean section, either one or two or more previous cesarean sections, and again a history of previous myomectomy. And then if a woman is grand multi, so and then in a grand multi we should be very careful in using either oxytocics or prostaglandins, because once we use these agents for induction of labor in these women, the chances of uterine rupture can be there. So again grand multiparity is considered to be a risk factor for uterine rupture. And then if a woman has malpresentations, like the malpresentations can be anything. It can be a brow presentation, face presentation, or sometimes even a transverse lie and then a shoulder presentation. So suppose if we don't diagnose or recognize that this is a malpresentation, and then if a woman goes into labor, so the chances of rupture can be there, because these are the fetuses which cannot progress during labor. So malpresentations, when they are unrecognized or undiagnosed during labor, can lead to uterine rupture. As same is the case even with unrecognized or undiagnosed cephalopelvic disproportion. So that's the reason whenever we want to induce, or whenever a patient is in labor, especially primary gravida, so we are supposed to always do a pelvic assessment and rule out whether there is a cephalopelvic disproportion, because if it is unrecognized or undiagnosed and then the patient goes into labor, the woman goes into obstructed labor, and again if we don't realize that she is going into obstruction, it can result in a uterine rupture. So obstructed labor again leads to uterine rupture if it is not recognized. And then whenever you are using any oxytocics or prostaglandins for augmentation, particularly in women with high parity, or else if a woman had undergone previous one cesarean section, we should be very judicious to use these agents, because the chances of rupture again are high in these cases. And again high doses of misoprostol as well can lead to uterine rupture. So whenever we want to induce any patient for whatever indication may be, so we are not supposed to use more than 5 doses of misoprost. So in case if a woman does not set into labor, even in spite of using 5 doses of misoprost, we label them as having a failed induction and go for a cesarean section. And then the other reason is whenever a woman had to be delivered through instruments, so most often it is a forceps delivery. So usually with outlet forceps and low forceps, usually it will not result in any uterine rupture. But in case if you use this Killian's forceps, so if you are not well trained or if you don't have expertise in using this Killian's forceps, so injudicious use of this forceps can result in uterine rupture. And the other possibility of having uterine rupture during labor is in conducting the breech deliveries. So whenever you are conducting an assisted breech delivery, again because of the manipulations that we do, it can result in a uterine rupture. And again, the rare causes of uterine rupture during labor. Again, these are the case reports. So even the presence of tumors, it could be a fibroid, it could be ovarian tumor. So any tumors, if it is obstructing the birth canal, and if we didn't recognize that there was a tumor and the patient goes into labor, again it can be a rare cause of uterine rupture. And same is the case even with pelvic deformity. And coming to the causes after delivery. So causes of uterine rupture after delivery. So a precipitate labor. So rapid delivery can result in uterine rupture, particularly in a grand multi again. And whenever the placenta is retained, so most often for a retained placenta, we do this procedure, that is manual removal of placenta under anesthesia, of always in an operating theater under aseptic conditions or aseptic precautions. So whenever we are doing this manual removal of placenta, there are chances that can result in a uterine rupture. And again, whenever we are manipulating within the uterus, so if a woman has set into or had this atonic pph, and we are using this intrauterine balloon for control of postpartum hemorrhage, so whenever we are doing such manipulations, we should be very gentle, so because again they can cause rupture of uterus. And as we have just discussed, the presence of placenta accreta, because it tries to invade into the muscle, so again after delivery also this can give way and cause uterine rupture. So those are all the different causes of uterine rupture during pregnancy, during labor, and even after delivery also. So coming to the diagnosis of uterine rupture. So what symptoms and signs the woman will have if it was a uterine rupture? See, if it is only a dehiscence, the patient will not have any symptoms. So it could be asymptomatic. So this occurs when the fetal sac herniates through an avascular scar and the uterus is retracted. So in these type of cases, we don't see any symptoms as such. And then just prior to the uterine rupture, the woman will be very restless and she will have a constant pain abdomen in the, particularly in the lower part of the uterus. And then once it is a uterine rupture, so the woman will go into shock. So usually we see signs such as tachycardia, hypotension, and then initially she will have tetanic uterine contractions, and then that will give away. So we find in the fetus the CTG abnormalities. So suddenly in the fetus we notice that there will be sudden and persistent bradycardia, so which usually suggests that there is a fetal compromise. And then when we do a parabdominal examination, so the fetal parts will be very difficult to palpate, because now that the fetus is into the peritoneal cavity, so we cannot appreciate the fetal parts per abdomen, because now that the fetus is into the peritoneal cavity. And then we find two palpable masses whenever we do this parabdominal examination. So one is your well retracted uterus, the other will be the fetus. So this usually suggests that the uterus has ruptured. And then just before the rupture, or sometimes we can appreciate this Bandel's ring. So this is nothing but the pathologic retraction ring, particularly we see when the patient is in obstructed labor. So once she is in obstructed labor, so the lower uterine segment tries to thin out, whereas the upper segment is well retracted. So a pathological retraction ring initially occurs and then it gives way. So even the presence of Bandel's ring is a late warning sign of impending rupture. So even at that time, if we don't intervene and do a cesarean section, ultimately it goes the uterus is going to rupture. So this pathologic retraction ring or the Bandel's ring usually appears before uterine rupture. When it occurs, particularly this thing is usually seen secondary to obstructed labor. And then the following rupture, see, there will be sudden feeling of something giving way with complete cessation of uterine activity. So once the uterine ruptures, the woman tells us she will have a feeling that something has given way, and then the uterus stops to contract. So a sudden feeling of something giving way with complete cessation of uterine activity is usually seen. So again, when we do parabdominal examination in these cases, the uterine counter will usually be lost because it has ruptured. And then the two swellings may be clearly distinguished. So one is the fetus that is lying within the peritoneal cavity or the abdominal cavity, and the other thing, the other palpable mass or the other swelling will be your uterus which is now well contracted and well retracted. Now that, and then it stops to contract, and then the fetal parts, because now they are freely lying in the abdominal cavity, they may be easily palpable because they are lying freely in the abdominal cavity. And then there can be a vaginal bleeding, but then even if there is a vaginal bleeding, it will be very less. The amount of vaginal bleeding will be very less, because whatever bleeding that occurs secondary to this rupture will be within the peritoneum, not a vaginal bleeding. And vaginal, on doing a pervaginal examination, you will appreciate that the presenting part has receded up, so which was otherwise a bit low down. So suppose, say, if the vertex goes at zero station, so once it ruptures, the fetus will move up. So that is what we call it as loss of presentation or loss of presenting part. So on vaginal examination, it reveals that the presenting part has been receded up, because now that the rupture, with the rupture, the fetus will lie in the peritoneal cavity and there is receding of your presenting part. And then there will be bleeding into the abdominal cavity, which can be profuse, and depending upon the amount of bleeding that occurs, so the patient or the mother goes, or she will have signs and symptoms of shock, and then she will collapse if you don't diagnose this and resuscitate the woman. So ultimately it can result even in a maternal death. So the amount of bleeding depends upon, again, on the location of the scar relative to the vessels. So in case if the rupture extends into the broad ligament, so gradually increasing abdominal pain, and we will see that the mass, you can even appreciate that there is a very tender abdominal mass. So in case if this rupture has extended into the broad ligament, so the patient will have increasing abdominal pain, and then we can appreciate a very tender abdominal mass. And then your CTG, as we have just discussed, because there can be sudden and profound bradycardia in the fetus because of the fetal compromise. So an abnormal CTG is usually seen in 55 to 87% of uterine ruptures, and the most common fetal heart rate abnormality that we see on CTG is a bradycardia. And if you see the uterine activity, we can see the staircase sign. So this staircase sign is nothing but a stepwise gradual decrease in contraction amplitude, followed by a sudden onset of profound and prolonged fetal bradycardia. So this is what is a staircase sign. So on doing a CTG, so we can appreciate, or we can see these kind of CTG traces. So it is, this trace is called preterminal CTG trace. So just before the fetal death occurs, we see these kind of traces. And this is one trace showing deep decelerations. So the fetal heart rate, the baseline was initially 120, but then we find there are decelerations, so falling to even 60 and even beyond that. And these are the atypical variable decelerations appreciated on CTG. So the decelerations are variable, atypical, and the two variable decelerations on CTG. So these are the kinds that we expect on CTG whenever there is a uterine rupture. So coming to the pregnancy following uterine rupture. So we are done with the causes, how to diagnose a uterine rupture. So now we are going to deal with a pregnancy following uterine rupture. That means the woman had a previous history of uterine rupture, and then again after rupture, if she becomes pregnant. So pregnancy following uterine rupture. So if the uterine rupture is confined to the lower segment, the risk of rupture in a future pregnancy is 6%. Whereas if the rupture involved the upper segment, so the risk is increased to 32%. And repeat cesarean section prior to onset of labor. So this is how we need to follow this algorithm in a case of pregnancy following a uterine rupture. So in the initial antenatal care and risk assessment, so we usually decide or in a woman with a scar, I mean to say woman with a scar, not necessarily the uterine rupture. So a woman who had a previous scar, one scar at least. So we usually do this antenatal care and risk assessment whenever she has come for our or her regular checkups. And then once we have done the risk assessment, so we decide her whether she is for a planned VBAC or she should go for an elective cesarean section. So the cases, like in case if she had a previous cesarean section, and then if she has some other obstetric indications like previous cesarean section again with uh, other obstetric indication, like it could be a case of preeclampsia or a multiple pregnancy, or else if the pelvis is not adequate, so those are the indications for again going for an elective repeat cesarean section. And in case if a woman is for elective cesarean section, we usually plan it 39 weeks. So in a woman with a previous cesarean section, so we need to do a risk assessment and decide which woman can be given a planned VBAC, or else which woman can be given a elective cesarean section. So in case if the pregnancy was complicated by, what is this, just a second. So in case if the pregnancy is complicated by any other obstetric reason, we need to go for an elective cesarean section. So if not, we can give always a planned VBAC. So again, once she is decided for a planned VBAC, again we have again two things. So one thing is a woman can have or go into a spontaneous onset of labor, or sometimes if she doesn't go into spontaneous onset, we need to induce her labor. So once any woman with a scar is in labor, we need to always go for a continuous electronic fetal monitoring, because in case if the uterus ruptures, the first sign that tells us that there is uterine rupture is your abnormal CTG. So we need to always go for a continuous electronic fetal monitoring. And then of course both the mother as well as the fetus, of course fetus you are continuously monitoring, and even for the mother we need to keep a close watch on her vital signs. So in case if you are monitoring and there are some signs which suggest that there is a uterine rupture, so we need to go for a laparotomy. So once uterus has ruptured, we need to go for a laparotomy. So in case if her labor is proceeding normally, so we need to do ARM at around 4 centimeters and then continue her care and see. So at any stage of labor, if there are signs and symptoms of uterine rupture, it is better for us to go for a laparotomy. So we need to have certain list of good clinical practice points. So particularly in a woman who becomes pregnant after a previous cesarean section, so we need to always have a proper antenatal counseling and do a proper risk assessment, and then it is always better to involve a consultant. And then in case if you want to give a planned VBAC for a woman, so ideally in a place where you have suitable staff and you have a well equipped delivery suite, so those are the areas or hospitals where you can give this planned VBAC. And once you decide or once she is in labor, we need to always have a continuous electronic fetal monitoring, because an abnormal CTG will be the first sign of a uterine rupture. And then once it is a rupture, we need to have resources for doing an emergency cesarean section. So in case if you are suspecting a dehiscence, so we need to have resources for doing an immediate cesarean section within 30 minutes. And then or else in cases where a woman particularly needs either an induction or augmentation of labor, it is ideally better for a senior person to be involved. And in these cases again epidural anesthesia is not contraindicated, and we need to always have an advanced neonatal resuscitation whenever we are giving these planned VBACs. So these are the list of good clinical practice points that we need to adhere to. So to conclude, the signs and symptoms of uterine rupture are typically non-specific sometimes, and vaginal birth after a previous cesarean section needs to be looked after in a well-equipped center where we have appropriate staff and then appropriate facilities for doing an immediate cesarean section. And also we need to have even neonatal support as well to resuscitate the baby in these cases. So this is about the uterine rupture, the various causes, how to diagnose, and how to deal a woman who had a previous cesarean section. Thank you.
ఇంతకుముందు కల్పన మేడం అక్క వచ్చి దగ్గరికి ఇంతకుముందు కల్పన మేడం కూడా వచ్చినప్పుడు సోఫా అనుకున్నాను.